because so this is a 56-year-old female, pain on both the knees, and her X-ray is like this. We have done a bilateral TKR robotic assisted in a single sitting. These are the post-op X-rays. After 2.5 months of the primary surgery, patient presented with pain on the left side, and it looked directly like an infection. So we took it, and we have done a DIAR procedure after 2.5 months. And
did you aspirate the knee before doing a DIAR procedure?
We have not aspirated the knee before the procedure because clinically I felt it is a straightforward infection, and I don't want to waste any more time because I want to open and clean it. At that time we have taken these.
Prof, is it indicated to aspirate this knee when the ESR CRP high with the clinical suspicions of infection?
If you have a clear indication for DIAR and an acute infection, it is not necessary, because you can, if you perform the DIAR, you can take a lot of samples during the procedure. And these samples, tissue samples, are even better than fluid. So I think it's okay if you perform a DIAR, otherwise you have to.
Yes, sir. Because we wanted to go directly for the DIAR, because looking at the knee clinically and the patient-wise, it's a straightforward infection.
Okay, so intraoperatively you took samples and...
We took samples, and we got one sample synovial tissue, we got Staphylococcus aureus, and the pus it gave Klebsiella pneumonia. So we have got two organisms we got at this point of time.
How many samples did you send?
We have sent 7 samples, sir, from pus, from femoral tissue. You can see from all those culture reports I have put there. So
so from the out of 7 samples, there are 2 samples which have grown, which are 2 different organisms.
2 different organisms.
Okay. So how relevant it is?
Because I believe the microbiology report, and I thought this is a multi-organism infection.
Since you have got Staphylococcus, even it comes out in one of the cultures, then it is pathognomonic.
Yes.
Prof, do you agree with it?
Yeah, if it is Staph aureus, yes.
Staph aureus, then it is...
Staph epidermis not, but
yeah.
Staph aureus, yes.
So, but if it is coagulation type negative Staphylococcus, then probably it may be a contaminant.
Yeah, this is a clear-cut case. So, both the organisms have been sensitive to piperacillin and tazobactam. So, we are given 4 weeks of IV and followed by 2 weeks of oral based on the cultures and by the advice of the infectious diseases. So 2 months after the DIAR procedure, patient complains pain, and there is a discharging sinus after 2 months. So once she presented like that. So debridement, joint prosthesis removal, and antibiotic cement mounts we have done. So we are totally taken out, and we have done a.
How many of you do a second DIAR procedure? Prof, do you agree?
It's contraindicated. No second DIAR procedure.
So never do a second. One DIAR procedure, if it fails, it's better to go ahead for the explantation of the prosthesis. Yes?
So we have done this thorough debridement and gone for the spaces. This is the post-op X-ray. Now the cultures what we have done from the femoral notch, we got a no gram positive or gram negative. From tibial condyle, we got Klebsiella pneumonia. So from the tibial intramedullary, we got nothing, and from the synovial fluid, we got Klebsiella pneumonia. And from the tibial...
1 second. We do have done a one-stage exchange, Prof, in this patient.
In this patient, yes, because one-stage exchange, because we know the bacteria and we know the susceptibility. And these are the main prerequisites for one-stage exchange.
Even in presence of sinus, you will go ahead.
Yeah, even and especially in presence of sinus, because we know that sinus is not a contraindication for a one-stage exchange. In the opposite, in the sinus you have a canalized fluid out of the joint. If you don't have sinus, it's spread under the skin and in the whole soft tissue of the joint. So a sinus is not too bad. You can excite the sinus, and that's it usually.
Okay.
So now we thought we got one organism, and the antibiotic sensitivity has moved from Before it was 5% tazobactam, now they gave it as a meropenem. So we have given 4 weeks of meropenem and followed by at the advice of the first and second preferential
How
antibiotics.
did you decide about what antibiotics you are giving? There are so many antibiotics which are sensitive.
See, the microbiologist gives which is more sensitive.
So you discussed with the microbiologist and they suggested to give meropenem.
I feel orthopedic surgeons should discuss with them because
Yeah,
our
that's what the
understanding is,
message we want
very
to
less
give, yeah.
regarding this, what antibiotic.
Yeah.
So now, 3 weeks after the joint process removal and antibiotics, patient developed wound dehiscence. This is what slowly it is, there is no discharge, but the wound is not healing properly. This is what we followed up. So necrotic tissue, debridement, and we removed all the necrotic tissue. We wanted to get a closure for that. At that point, again, we have taken a culture from the wound and there is no growth on the superficial because we didn't open the joint at that time. This is done by a plastic surgeon. So after debridement and skin closure, intra-op swabs came sterile. Only the superficial ones, not in the joint ones. So we continued on advice of our specialist, we continued the second best antibiotic like ampicillin sulbactam. This is what happened slowly. The wound is not healing and the wound has become like this. So the discharge has stopped, but the wound is not healing and we have to go for a medial gastrocnemius flap cover over the raw area. So we have done this. The plastic surgeon has put a cover on so that this is the procedure what has been done. But after the culture also, we continue the antibiotics, but there is no response. Again, there is discharge starting coming from the wound. So there is a change of antibiotics given by the infectious disease specialist. We have gone for that. These are the cultures what we got. So again, it's a Klebsiella pneumonia. And there is a ooze coming from the graft again. So this is what finally it is leading to it. And then we've gone for an MRI scan to see what is the pockets of pus what we are there. There was a large intra-osseous abscess in the medial and lateral femoral condyles. So then we took it back. We opened the flap again and did a thorough debridement again. So you can see the flap what we have put, we took away the flap out and then a thorough debridement has been done and we cleaned everything and finally we went for this beads, intra-articular antibiotics. This is what the final we did for this patient. So at this time the report has come as Acinetobacter baumannii and E. coli. So on the tibial side, so this is what you can see. This is Acinetobacter baumannii and the sensitive antibiotics what they have put. So there is a E. coli, there is Acinetobacter and pre-existing Klebsiella. So all the gram-negative bacteria are there inside that joint. So since 2 months after that debridement, so many antibiotics we changed, tigecycline, everything has been done. We are going
What
very...
is the present status?
So patient and myself decided we'll stop all antibiotics. Patient got fed up and I myself got fed up. So we stopped all the antibiotics, we put a vac dressing, we put it. So this was the initial days, this amount was draining per day. And today, present clinical picture is the patient is like this. There is a small sinus which has to be healed and that's what. This is the course of so many antibiotics what we have used. You can see the range of antibiotics what we used, tigecyclines, minocyclines, all the different types of bacteria.
Okay.
And still we don't know what to do next.
Okay. So it's the same organism which has grown almost 3 times, Klebsiella pneumoniae. What is the significance of this?
Could we think on a different line and maybe when we were debriding the second time, could we have offered patient to go for an arthrodesis rather than hoping to do a revision in such a case of multi-resistant with multiple organisms?
Neeraj, anything before we move to Dr. Gerke?
I agree with him. So in such cases, it's better to offer arthrodesis then plan for 2-stage revisions.
Did you apply VAC beforehand?
After the second debridement, we started, once the skin is not healing properly, then we started to use this VAC.
Okay.
So, but after stopping 2 months of antibiotics completely, patient has improved better.
Okay.
The discharge has come down. And
Okay,
are not
we have
taking-
take final comments from Dr. Gerke.
No, first of all, we have to criticize ourselves. What probably we made wrong in this procedure. So first of all, after 2.5 months, you did it there. So probably that was not the right time. It was too late to perform it there. So, and secondary, you have to ask yourself, have I really done a thoroughly debridement in all my procedures? And this is the most common mistake, that the debridement is everything. And if you ask yourself, or first of all, who did it? Did it the registrar or an experienced surgeon? Mainly the registrars are sending into your debrided, come back. So the debridement should be done extremely thorough, extremely radical. So we have a lot of guests in our OR, and when they are watching and observing our septic surgeries, and you know it, when they say, oh, now you can stop, everything is done, then we start with the debridement. So, and this is how we perform our septic surgeries, and that's a main mistake. But I mean, it's a terrible case, and arthrodesis is, so we use never mobile spaces in knees. It's our philosophy. We always use static spaces to give some stability, and yeah, but and now I think it's still infected. And you must be extremely radical in your next debridement, and don't hesitate to remove bone. I think the source of this always upcoming infection is the bone. There's some kind of osteomyelitis, and you never really resected the bone. That's my comment.
Thank you.